Hi guys, and welcome back. In this video, we're going to talk about the anatomy of abdominal wall and inguinal region. So first of all, what is the abdominal cavity? It's basically the cavity that is continuous with the pelvic cavity and is bounded superiorly with the diaphragm and inferiorly with the pelvic diaphragm. So diaphragm separates your abdominal cavity from the thoracic cavity, and then you have anteriorly your anterior abdominal wall, which is formed by three layers, and we're going to talk about that as we proceed. And then posteriorly you have the your vertebral column, you have the psoas major muscle and quadratus lumborum. And so moving on, you guys know that it's very important, and as we proceed in the videos of this module, you'll find that it's very important that we divide the abdomen into regions, because each one of the regions is going to reflect a problem in an organ. And as you proceed, you will hear that in which region do we know the problem of certain organs. So in order to understand that, and as we proceed, in order to understand what do we mean when we say that the stomach lies in the left hypochondriac region and epigastric and some of the umbilical and whatever, you need to understand the 9 regions of the abdomen. And that is important for differential diagnosis. So how do we divide the abdomen into 9 regions? We have one midline line that goes from the jugular notch all the way down to the symphysis pubis, passing through the umbilical or umbilicus. And then we have 2 lateral lines. You guys know that you have the clavicle here. So at a mid-clavicular point, you go all the way down to the mid-inguinal point. So this is the inguinal region, the inguinal ligament. So once you go into the inguinal mid-inguinal point, it means this is your lateral lines. And then you have 2 transverse lines. So these are the 3 vertical lines. You have 2 transverse lines, one that goes through the pylorus of the stomach, and that is basically at the lower border of L1. So here you have the L1 vertebra, and this is what we call the transpyloric plane. And then you have L5, and that is the transtubercular plane, which is going through the tubercles of the iliac bone, and that is basically at the upper border of L5. So this is the transtubercular planes, right? So you have 2 vertical planes, 2 horizontal planes, and 3 vertical planes, and that will give you finally 9 regions, 3 midline regions. So 3 midline, the umbilical around the umbilicus. Above that you have epigastric region, below that you have the hypogastric region, and then it will give you 2 lateral similar regions, one above, which is below the costal cartilages, and cartilage in Latin means chondriac or chondria or whatever, the chondra kind of term. So that's why we call it hypochondriac region, because this is below the costal margin here, or the costal stuff related to the thoracic cage. All right, and then this is lumbar, because this part in Latin means lumbar, and this is the iliac region, right and left. All right, so these are the lateral regions. You have them on the right and you have them in the left, and each one of them has its important organs. Now, what are the layers of abdominal wall? In the abdominal wall, we have the rule of 3. So basically we have 3 structures covered by 3 structures and lined by 3 structures. The 3 structures, you have them in the middle. They are basically your muscles. You guys know that in the abdomen we have 3 muscles, one external, one internal, and one innermost. I'm not talking about the thoracic, but I mean this is just to refer to the innermost muscle out of the 3, which is the transversus abdominis. All right, so you have the external abdominal oblique, and then followed by internal abdominal oblique, and then followed by the transversus abdominis muscle. All right, these are three muscles in the center, and now those guys are covered outside by three things. Well, the first one is basically the skin. So you guys can see that the skin is the outermost structure we have. And then you have the superficial fascia, and the superficial fascia is actually composed of two layers: superficial fatty layer, which is what we call the Kumper's fascia, and then deep membranous layer, which is what we call the Scarpa's fascia. All right, so you have those three muscles here. The muscles, they are three, and then outside you have skin number one, and then in the superficial subcutaneous fascia or superficial fascia, you have two layers, one fatty and then one membranous, and then these are the three muscles. All right, so this is number 4, 5, and 6. And then the last thing you guys have here is basically, forget about this loops. All right, basically you have the fascia transversalis. So in this term, fascia, this is what we mean by fascia transversalis. And then this is followed by extraperitoneal fat. So this is number 8. And then the peritoneum, which is the parietal peritoneum. So these are basically making your wall. All right, guys. So you have three muscles covered by three structures, which is the skin and the two layers of superficial fascia. And then you have three structures deep to them, which is the transversalis fascia, extraperitoneal fat, and then the parietal peritoneum. Someone will come and say, all right, where is the visceral peritoneum? Great. The visceral peritoneum is actually covering the organs. This is not part of your wall. All right, so these are the 9 layers of your wall. So if you guys look at a diagram showing you these layers, so you will find that the skin, superficial fatty layer, which is the Kumper's fascia, and the Kumper's fascia, guys, it's continuous down all the way with the fat in the perineal region and the fat of the thigh. And then you have the third layer, which is the Scarpa's fascia. It's basically as if you're having a plate and a fat on top of that. So the plate is basically the membrane, which is the Scarpa's fascia, the white Scarpa's fascia, and basically the white fat here is the Kumper's fascia. It's covering the Scarpa's. All right, so the Scarpa's fascia is going to continue down, and we're going to talk about the Scarpa's as we proceed. It's a very important structure, and we need to know it's continuous with what. And then once you remove them, you will find your muscles. So the external oblique muscle comes first, or so this is the external oblique, right? And then you have the internal oblique, and then you have the transversus abdominis muscle. So we have external oblique, and then you have the internal oblique, and then you have the transversus abdominis. Okay. We're going to talk about the rectus sheath as we proceed. Okay, so they have three muscles. External oblique comes from the lower ribs and comes from the thoracolumbar fascia, from the iliac crest. And all of them basically, in order for them to get attached, they will form a broad flat tendon, because in the abdomen, you cannot have the regular kind of tendon. So it's aponeurosis, guys. So each one of them is going to convert into its tendon. It's not conversion, it's kind of attachment to the connective tissue that wants to attach the muscle to the destination, and that is going to be aponeurosis. So the external oblique will make external oblique aponeurosis, and then the internal oblique will make internal oblique aponeurosis, and then the transversus abdominis will make aponeurosis of transversus abdominis, and three of them are going to come all the way in the front, and they are going to envelop the rectus abdominis muscle. All right. So we're going to talk about this in the next slides. So let's continue with the muscles. So we have the external abdominal oblique, and then it's followed by the internal abdominal oblique. And if you guys look at the internal oblique, I'm not going to talk about the specific origin and insertion. It's just there everywhere. I just want you to pay attention to the idea that first of all, the running of the fibers. External oblique is as if you're putting your hand in your pocket. It runs forward, downward, and medially. However, the internal oblique runs upward, forward, and medially also. All right, so it's opposite. If this is moving downwards, then the internal obliques runs upward. This is one thing. Another thing, if the idea of the transversus abdominis is confusing you with the internal oblique, remember one thing is that internal oblique, and sorry, the transversus abdominis, guys, it takes origin, you guys, to me it looks like a triangle, because it takes origin from the lower ribs here, and from the inner surfaces of the lower costal cartilages. So this is all giving origin, and it comes out of the lateral 1/3 of the inguinal ligament. Lateral 1/3 only, you guys, the transversus abdominis, and of course it runs transversely and it stops at the musculo-aponeurotic junction. All right, now what about the internal oblique? The internal oblique, guys, it doesn't come from here. It doesn't come from the inner surface of costal cartilages of this. It comes from lateral aspect. All right, so it comes out of here from the lower inferior surface of lower ribs laterally, and it comes out, of course, from thoracolumbar fascia, and it comes out from down here from the lateral 2/3 of inguinal ligament. Remember that the internal oblique comes out of the lateral 2/3, guys, 2/3, and this is very important in the inguinal canal. When we're going to talk about the walls of the canal, remember that 2/3 is coming, the internal oblique is coming out of the 2/3, because that will give me reinforcement to the wall, and it will make sense that only internal oblique is giving me the reinforcement in the anterior wall. Okay, so this is here how to differentiate between the muscles. And after that, of course, you have your extraperitoneal fat and parietal peritoneum and fascia transversalis. And what is the fascia transversalis, guys? It's basically the innermost structure. It's basically, it should be here, because these are parts of the rectus sheath, and the rectus sheath is formed by the aponeurosis of the three muscles. If we want to look at the layers, again, this is in a real cadaver, superficial dissection. The skin has been removed. The fat is kind of those kind of fat that is on a plate of the scarpus fascia. So basically the scarpa is just the whitish kind of membrane down there, and if you remove the whole fascia, the three layers, you're gonna see that you started with the muscles. Where is the muscle here? All right, nice question. Your muscle already finished in the lateral aspect, and it continued as the aponeurosis, and here you have the fusion of the aponeurosis of the three muscles. Not all of them are here anteriorly. We will have a story about the aponeurosis as we proceed with the rectus sheath, but let's just leave this for a while. Before we talk about the rectus sheath and the change in that, you guys need to understand that the okay, fine, the comparse fascia, which is a superficial fatty layer, it's continuous with the perineum and the thigh. It's a fatty layer. Now, you guys, the scarpus fascia, which is the deep membranous layer of the superficial fascia, and we cannot say the word deep fascia. There is no deep fascia in the abdomen. There is no deep fascia in the face, because this will be difficult for me to have facial expressions, and this will make it difficult for pregnancy, for distension of the abdomen. So we don't have deep fascia here. These are two layers of the superficial fascia. All right, now the scarpus fascia, guys, as you trace it down, you will find that it's continuous with the membranous layer, with the fascia that envelops the genitalia, and it wraps around the genitalia, and it comes back, all right, to get attached to the perineal membrane. So you guys, the scarpus fascia, as it gets down, it's continuous with the buccal fascia of the penis, and it's continuous with the dartos fascia of the scrotum, and it continues all the way until you reach the perineal membrane. And because you know that from the reproductive system, that if you look at the layers, you will find that outside you have this membranous layer, and then here you have your genitalia, and then because that will give you the perineal pouches. I know that this is a bit advanced topic, and it's explained very deeply in the reproductive system, but I just want you to understand that in perineal region, where you have your stuff related to the reproductive digestive system, internal stuff and external stuff, and the external is the genitalia, you have something like a sandwich-like appearance. It's not appearance, it's a sandwich-like fashion. It's a membrane that is covering the genitalia outside, and a membrane separating two pouches, and a membrane is separating these structures here from the deep structures there, and this is what we call the superficial perineal pouch and deep perineal pouch. Now, why do you need to know that? Because I just want you to know that in the urethra in male, you guys, you have different parts of urethra, and it's explained in the reproductive module. If I'm telling you that you have a membrane covering your external structure, and there is a membrane that is separating your superficial perineal pouch from the deep perineal pouch, you would expect that if you have a rupture in the outside part of the urethra, which is like the bulbar urethra or benign urethra, that is going to cause accumulation of the urine in the outside pouch, and that pouch is basically continuous with the scarpa, which is basically a membranous layer of the abdomen. So that patient can develop that urine, and it's going to accumulate all the way to the lower abdomen. It's gonna go all the way to the abdomen. It's not gonna go to the thigh because there is a fusion here in the fascia lata, and it's not continuous down. There is a fusion, the scarpa's fascia, it's gonna fuse with the fascia lata, so the urine is not gonna go to the thigh, but it is going to go all the way to the lower abdomen. However, and this is what we call the superficial extravasation. However, if you have a rupture in the preprostatic urethra or the membranous urethra or prostatic or any of the deep parts here, that is going to accumulate the urine around the prostate and the bladder, because this is going to be deep to the perineal membrane, and this is a totally separate pouch. So basically you have a membrane, perineal membrane, you have deep pouch, all right, you have superficial pouch, and the superficial pouch is continuous with the abdomen. So if I'm trying to accumulate stuff here, it's not gonna go deep there, and if I'm trying to accumulate stuff here, it's not gonna go there, okay, because there is a separation, clear separation between them, which is the perineal membrane. All right, guys, so that will give you the idea of the difference between the superficial extravasation and deep extravasation, and this is a very important clinical topic. And all right.